And I just think the scripture was perfect for Sonny today. I feel like he is looking for the lost sheep. I feel like I am the lost sheep. And I have one tiny story to tell you about sheep that some of you may identify with. My Sunday school teacher in Crete, Nebraska, was Miss Darling. And we kept attendance by each of us having a meadow. And each Sunday you came to church and went to Sunday school, you got a sheep to lick and stick on your meadow. And some of us had a few sheep. Some of us had a lot of sheep. John Lothrop had lots of sheep. He lived a block from the church. Some people only had one sheep. But Miss Darling made sure everybody was welcome. And she probably snuck around and put a few sheep on various people's cards anyway. So can you believe it? Every time I hear the scripture of the lost sheep, I think of that Sunday school classroom and Miss Darling. So Sunday, thank you. As many of you know, he's a physician associated with Upstate, and he is always a person who is looking for a way to extend what many people have to what many people don't. And I also think you know that right now there's another round of Medicare cuts coming. They're already in place, and it's just getting worse and worse. So I introduce you with gratitude.
Thanks. Thank you, Nancy. Good morning. Grateful to be here. This church means a lot to me. Not going to spend a lot of time on this, but 7 years ago I went through a very painful divorce, and this was one of the places I came to and found a lot of comfort here. So I'm really grateful to the church, and it's so nice to see so many familiar faces. And yes, sir.
It's going to be important for you to speak into the mic.
I actually have a mic right here. You can't hear?
Maybe just we'll move the mic a little closer. Thanks.
Is that better?
Yeah.
Can everybody hear okay?
Yeah, thank you.
I'm the person who posts these things online.
No, thank you. I want everybody to hear this. This is important. So yes, no, I'm very grateful to this church personally in my spiritual journey. So that aside, thanks so much for the introduction, Nancy. I do spend a lot of my time worrying about some of the most vulnerable folks in our area. And the short version is that medical debt is a huge issue, and particularly in central New York. I'm not going to spend a ton of time on statistics, but in 2023, a survey was done that found a quarter of Syracuse city residents had medical debt. So 1 in 4 people. And it was something like 40% of families of color. So it was very difficult for our Black and brown population. So if I move back 2 or 3 months ago, I saw an article, and Pastor Craig actually saw the same article and sent it to me after we started talking about this. It was in NPR. It was about a church in Winston-Salem, North Carolina, a bipartisan church, where Republicans and Democrats in the church came together to raise $17,000, and they settled $2.2 million worth of medical debt. And I thought, wow, that's really powerful. I'm going to write a check and then move on to the next thing. And then I'm an organizer, so in my mind I thought, well, I could do that, or I could talk to other people and see if we could do even better. So that led me through a series of research and conversations with statewide experts and national experts on medical debt, a journey that was, I'm going to just abbreviate it for you, but it was quite an experience. Here's what I learned. So in 2023, there were a series of articles written in the local media about the hospital I've been affiliated with for 20 years, being one of the hospitals that sued people in the state more than any other hospital for medical debt. So it's horrifying, right? It's very upsetting. And so there was a big campaign, not just focused on what was going on here in central New York, but statewide. What can we do as a state? And the legislature was interested. What can we do about medical debt? So again, the short version is New York passed some of the most progressive legislation having to do with medical debt in the country. And it's been replicated in a number of states, and some states have, it's arguable who has the strongest, but New York is on the cutting edge of medical debt legislation. For example, medical debt is banned from credit reporting now. So that's huge. Medical businesses cannot attach your wages. They can't put liens on your home. They can't essentially force you to pay for medical debt in those ways. That's been banned. The lawsuits that had happened before have almost completely gone away. So there have really been these huge steps forward. So there's a lot of good news. The not so great news is that there were unintended consequences, I believe, from the changes that have led to medical debt being, it appears to be almost virtually unmeasurable at this point in time. Before, you used to follow credit reports to see how much medical debt was out there. You used to follow lawsuits. You used to see who was having their wages garnished, etc. That's all gone, and so when you go and look, say, on the Urban Institute to look at how much medical debt is in New York State, 0%, right? Which is, exactly. That's exactly the response I had. So it appears we don't have great ways of measuring this data at this point. And so what I was trying to do was figure out how much debt there was out there. We could have a fundraising campaign, raise some money, and retire some of that debt. But what I came up with was this model, and we'll get into it a little bit. But essentially, that sure, we can raise some money and we can retire some debt, but that doesn't help us get in front of that debt. We'd rather people didn't have any debt at all, right? And the laws that were passed in 2024 were designed to help avoid that debt through things like there's now one form that all hospitals in the state are required to use for financial assistance. So you get a $10,000 medical bill. The hospital has one form that you can fill out and apply for financial assistance. And it applies for people up to 400% of the federal poverty level. And it applies to people who are underinsured, which is a significant part of the population. I'm sure many of you can identify with that. You have insurance, and yet you still pay thousands and thousands of dollars a year in co-insurance and deductibles, et cetera, right? So the laws have been strengthened. What happens, unfortunately, is this isn't always the primary focus of the hospitals or medical businesses. And so they have to pay staff to do this. It takes time, it takes resources. So part of this model for helping people with medical debt is how can we strengthen our local nonprofits, the hospitals themselves, how can we collaborate with them to make sure that all the laws are being followed and that people are getting the maximum amount of medical assistance. Because if you talk to people who get huge medical bills, they usually just panic and put it on a credit card bill, on a credit card. Well, once you do that, you lose all the protections from the laws that were passed a couple of years ago. It's no longer medical debt, it's credit card debt. So there are all these different things that people need to know that navigators can help with, that hospital financial assistance, there are local institutions, and we'll go through this in detail. But I just want to provide like a brief overview of what was originally primarily more of, I was thinking a quick fundraising project, has turned into, we could build a more robust system that helps people get in front of the medical debt so that we don't have to have fundraising to forgive it in the end. I hope this is making some sense. I've been doing a lot of talking, so I'll pause right now. Does anybody have questions on what I've said so far?
I'll just make a comment. When I was working, which was 5 years ago, I was at Upstate.
This is being recorded, so that's why we're going to do the mic thing.
Okay.
Thank you.
I don't know if this has changed since I was working at Upstate 5 years ago, but one of the other problems is that the hospital itself has difficulty with insurance companies and their contracts. And so this becomes a problem for patients when there's some kind of dispute, and so they don't file any insurance. The hospital's arguing about what they're going to get paid from the insurance company, and then the client gets this really huge bill. So I don't know if it's still going on, but that's another piece of what happens at on the hospital side.
Thank you, Kathleen. Yeah, this is by no means a black and white issue. There are very complicated aspects to it that I'm glad Kathleen has highlighted.
So I assume that it is widely known and understood in the medical provider community that a certain amount of a certain amount of what is billed will never be collected. And so I wonder, I mean, assuming that's true, isn't it logically follows that a certain amount of billing reflects an inflation factor to cover that non-collection? In other words, are hospitals and doctors overcharging, knowing that they're not going to get full payment? And that means that the people who do naively pay the full bill are helping subsidize those who don't.
I mean, that's a whole nother talk, Doug. Those are important questions. That's not really the focus of what this is. But I mean, essentially, the whole system is so opaque and dysfunctional. It's hard to have any idea what's going on, right? But that's a whole nother talk. Esther, did you? Sorry, go ahead.
Oh, yeah, I was going to say her first, but what about the ambulance bills that also are kind of a part of this? Because, some of us, like myself, can't even afford $1,000 ambulance bill. And if we have to get transported to the hospital, that's money we don't have.
Oh, absolutely. It's medical debt. It all falls. That's why it's the leading cause of bankruptcy in our country. But absolutely.
It affects so much of life in general. One of the ways that it affects is, not only the self-esteem of the person who's constantly getting phone calls and letters that tell them that they are debtors, but also when they go to purchase a home. Now, you mentioned that, now it's going on the credit card, which it is. But is there a way for them to, is there a way for them to document that is in fact what that debt is? Or once it's on the credit card,
You've lost the protections of the law at that point. Yeah. So that's why we want to get ahead of it. We want to form a system locally, and ACR Health is probably the leading local organization to counsel people. So right now, if you have somebody who needs help, ask them to go to ACR Health, and that's the place to go. What I'd like to do, my fantasy is to form like an interfaith medical collaboration or partnership locally, that maybe one person at Plymouth is willing to get trained in this so that they can become a navigator, so that anybody at Plymouth would know that Esther Zorn has had training and is willing to talk to people about medical debt, and that Esther has some amount of knowledge so that she can help the person navigate through the hospital finance assistance or go to ACR Health. The Volunteer Lawyer Project is another group that helps people with medical bills as well. But that, so we have interest from the Islamic Society, some Black churches. I'd love to form a network locally so that we can help as many people as possible before they just panic, get that letter, right, and panic and put it on the credit card. And then it's, instead of being able to go through the hospital and talk to the navigator, you're with it, under the 400% federal poverty level, well, then the hospital has to do X, Y, and Z for you. And they have to apply for this, and this for you to help you with that medical debt before it gets on your credit card. So that's the general idea. Medical bill, we try to intervene at the interfaith or nonprofit. Maybe you're a part of a nonprofit that would be willing to have somebody to get trained as well to help out with this process. And the other piece is partnering with local hospitals. So Upstate has been identified and beaten up in the media over this. There have been significant changes and improvements, which are wonderful. So we want to partner with them. We don't want to attack them. I'm actually moving back to Upstate right now and negotiating a job. So we want to help and support Upstate to do the right thing and to help people. And they've done a lot of good over the past couple of years. Lawsuits are down like 99.8%. So there have been significant improvements, but we want to make sure those continue, and we want to help people before they get the medical debt, and then follow the outcomes and look at identity gaps. So I had a meeting Friday with some of the folks who helped write those laws in 2024, and I was asking questions, and it seemed like there was still some confusion about exactly the way things are now. So these laws are so new that I don't think anybody fully understands them yet. And so we need to identify the gaps, look at the outcomes, and figure out a system that we can use to follow medical debt right now, because nobody can tell you how much debt there is right now in Onondaga County. So I've asked Assemblywoman Pam Hunter's office, and they said they were willing to help to look into getting some of this data for us. So I'm hopeful that we'll have some more local data, and then hopeful that more and more people will be willing to get some education or training to form that network to help people early in the process as possible. Could we have a microphone to this gentleman here, please? Thank you.
Has there already been discussion about including dental into your program?
I mean, that would fall under medical debt. So absolutely,
Oh, is that okay?
yeah.
I know with Medicare they don't include dental.
Yeah,
it's separate.
right.
So it's sort of strange they don't. The
Right,
month
yeah.
isn't considered about.
Dentistry is expensive, and it's
Yeah.
it's difficult to find a dentist that's in network or even available sometimes, right?
Yeah.
Yeah. Dental is tough. Got three.
I just want to say one more thing. I think that most people do not know that there is hospital financial assistance, and there has been for a long time, but they don't advertise it. So, I mean,
Yes.
even just that piece alone, I think, would really be helpful.
Right. Yeah, that's it. I mean, we have one form now for people to fill out, but forms are so overwhelming for people, especially people in poverty, right? They think they just become cynical. Nobody's going to help me. Why bother filling out the form? We just want people. You don't have to be a world-class expert in any of this. Just someone who's willing to sit down with somebody and go through it and learn the process. Our healthcare system, navigating it, is a nightmare for people, right? I probably spend 5 to 10% of being a physician helping people navigate the system. It has nothing to do with, what I learned in medical school, right? It's just that people know I know a lot of people. Sonny, how can I get this? How can I get that? Okay, we'll get you hooked up with those people. That it's a shame our system is so fragmented and so broken, but that's I feel like that's like a big part of what I do.
Is there a way to use that fragmentation to our advantage? One hospital leveraged against another. I mean, that's not a very positive way, but in fact, does St. Joe's do something better than Krause, et cetera, et cetera?
Right. So the question was about how can we best collaborate locally and work with all the big players locally to form a more functional system. So I met with the chairwoman of the county legislature this past week, and a couple legislators were willing to meet and talk about this. And she said she's willing to call and work with the local hospitals to strengthen these protections that are here and make sure, because the hospitals need resources. They have to, people don't know about this process. So I do think that both our state folks and the county legislature are willing to work with us on strengthening this process, because yes, we have 3 large hospital systems here, and we want to work with them as much as possible to make sure people are aware of what assistance is out there, and let's form our own network as well to make sure people are getting where they need to get. And part of that is going to be tracking data. We want to track data to know what is going on, because right now we just don't. It's like a big black box. We don't really have a good idea of what's going on. There are some yearly disclosures that hospitals have to put out there, so we need some time to study those, and it takes time and takes expertise, and a lot. Like I said, a lot of these laws are brand new, so we're still just figuring a lot of this out.
Does ACR Health have a relationship with hospitals?
I don't know exactly what. So ACR Health, the financial assistance program is part of a hub and spoke program that's throughout New York State. They were identified by the folks who wrote these laws, called CSS of New York, wrote these laws. They were passed, and then they put in place an advocacy program throughout the state. So ACR Health. So I would imagine that they probably do pretty frequently work with those, but I don't know for sure. I did contact ACR Health, and they are willing to train. So if so I'm hoping to put together a group of, maybe 5 or 10 folks from churches and nonprofits locally who wouldn't mind getting some training and how they could help. and then being designated at their church or organization as the financial assistance, a medical debt navigator, something like that.
Sonny, this is great conversation. And I think it's really important for the community. I've been in the medical arena for a very, very long time, and the system has been broken for a very long time. And back what Kathleen just said, right? There's a lot of patients, even a lot of elders, my parents, and it's very hard to navigate the healthcare system these days. And it's been like that for a very long time. And what I would like to see, being done is how do we educate our physicians, right? And now, because those are the folks that are front line, right? The patients come in, but I think it's all time. Who has the time, right? You as a physician, you don't have the time to get into, this is the assistance that you can get for your prescription, right? Because we have a coupon that will help with a prescription and getting a little bit of a discount off of your prescription. Or you can, go to this website and see how you can get medical assistance. So my question is more of, how do we train our physicians? How do they get time? And they don't have the time to spend because they've got to move on to see the next patient, because everything is based on, Sonny might need to see, 13, 15 patients today. And I don't have the time to spend, nor does the practice. So it's a system that really needs to find a way to get better, educate, find a way to educate the patients that are coming in and how they can get the assistance that's out there. Because like Kathleen said, there is assistance out there, but we need to do a better job of making sure people are aware of it. Thank you.
Yeah, no, I think that's exactly right. How can we strengthen our system? And part of that is the providers themselves. And, again, one of my fantasies might be in every medical doctor's office, we just put up some signage, put up a pamphlet with a phone number and a contact. I mean, it doesn't have to be horribly complicated, but I think 20 years of being in town and working with the sickest of the poor and the poorest of the sick, they are completely overwhelmed with their next meal, with their rent, with the kiddos. These are systems problems, right? And it's, comes back to discussions many of you have about what kind of society do we want to build? How do we treat each other as human beings? What's the, what are the underlying resources we want to provide each other as, citizens and these are big discussions, right? And they're not going to get solved today, but I think about these things when I'm asked to, and I come in and see there's 10, 20 patients a day on my schedule, and they're all living in poverty and suffering from racism and living in traumatized communities with drug dealers outdoor and guns being shot. And this unfortunately it falls further and further down the list, but it has such a huge impact on their lives. And I wish I had better answers, but I think, I'm reminded, especially with the political discourse that's going on right now. I went to Mass at St. Lucy's, and there's a sign up there that says, when I feed the poor, I'm called a saint. And when I ask why they're poor, I'm called a communist, right? And I think that's so appropriate to this moment, right? Because it's there's a lot of name calling being thrown around for people who are simply care about, people's housing and their food and their, basic life. But anyway, this is not time for long political discussions, but
I was going to say, why don't we hold off on questions for a little bit and let you proceed with your presentation?
So really, I wanted to keep it simple today and wanted really to have the back and forth. This is the basic model. I'm happy to answer questions about that. The other piece was the fundraising piece and Undo Medical Debt. I've been working with them for a month or two, and they really haven't been able to get much more data to me. But that doesn't prevent anybody from contacting Undo Debt and writing a check to them and retiring debt. But the last they told me is we have $30,000 in debt in Onondaga County that can be retired for $352. So I said, well, I can write a check for that right now, but that doesn't solve this, right? And that the focus is this. We want to get in front of all this, but
Could
yeah.
you explain how a small number can retire a large number?
Yeah, so
I was going to say,
next up is up back. Okay, so the question was how, there's $30,000 worth of debt that Undo Medical Debt, the organization that one of them that collects debt. So what happens is I get a $10,000 bill, I can't pay it, the hospital writes it off. And then undue medical debt buys that debt. And debt collectors know that people are not going to pay these bills. Who could pay $10,000 bill, right? So they negotiate to pay for it for pennies on the dollar. So that $17,000 that the Winston-Salem Church raised actually retired $2.2 million worth of debt. That's how it works. I mean, you can't get a return like that on anything, right? But remember, this is debt that's been written off, and that still it's important. It needs to be, that $352 is important to get retired, and nationally it's important to get all this retired. And you see, if you Google this topic, you'll see people retiring huge millions and millions of really wealthy people retiring some debt for people. It has a big impact, small amounts of money. So that's why the return is so high. Back there, and then Nancy.
My question is just, where do the insurance companies fit in this whole picture? Like, I don't need to pay $0 for my medication, right? I could pay more and we could balance things out some way. I mean, I'm not a communist, but I feel like you're going after the politicians and you're going after the hospitals as a collaborative, but what about the insurance companies?
Yeah. So, I mean, insurance companies are part of this dysfunctional system that we have. That's our healthcare system. There's no, I'm not trying to villainize anybody here or make anybody into a hero. We're just trying to find a way to help people get ahead of medical debt. Insurance companies? Yeah. Sure. Insurance companies are corporations. Their purpose is to make a profit. So, I mean, this is the difficulty of our system. And nonprofits as well. Nonprofits, some of them can be even more aggressive than corporations in growing and charging prices, having monopolies. These are all large financial and economic discussions, again, that we're not going to solve today, but these are all, part of why, healthcare costs are wildly out of control. We pay twice as much per capita in this country for healthcare. It isn't even universal. That, in Europe, everybody's covered, and they pay about half per capita on average, and it's, all covered. Here we pay twice as much, and it's not all covered, and we have outcomes that are, the poorest amongst developed countries. Anyway, other talks for other days, but.
Yeah, first of all, thank you for mentioning insurance companies. To me, that's a really big piece of the issue around here, so thank you. But when I first began to hear about this and think about it and think about you coming, Sonny, I think one of the things that was the most exciting for me is over the years, Plymouth has taken on different issues and done different justice movements and part of things, but never alone. We've always been part of a coalition or other groups of sister communities. So that was the exciting part for me, that another piece of your vision was that it wasn't Plymouth, you weren't coming to Plymouth alone, but you're also part of reaching out, and that we might also do that.
Absolutely. So I wanted to start smaller so we could get the ball rolling and have some success. And I ran into, just learning more about medical death than I thought I ever would. But I'll just mention a few of the partners who are interested. So Reverend Burns from HOPS, the Islamic Society, the Rama Clinic. I have reached out to Father Fred, who always says yes. That's an amazing thing about Father Fred. He always says yes. Who else? I'm a member at First UU, Unitarian Universalist Church. What other groups? Oh, Rise. You guys are familiar with Rise. They're interested. In fact, Kristen, who's a therapist from Rise, has volunteered to be the lead, train the trainer. She wants to get the training from ACR Health and then be willing to train other people so that we don't completely overwhelm ACR Health, because ACR Health does a lot of amazing things for the community, and I don't want to dry up the well there. I'm really grateful for the work they're already doing. So my hope is that Kristen will get the initial training and then be willing to train people from all these organizations, and that from there we expand. We reach out to other partners in the community, and maybe we move from 5 to 10 to 20 to 40 local interfaith and nonprofit organizations that are willing to have somebody designated to help people through this system. Is that time is involved? what kind of time is involved. So I don't know yet exactly what it would be, but initially ACR Health said something like an hour training would be enough to get people. We're not trying to train like volunteer lawyers project. Those are lawyers who, and they're kind of, they would be like the third tier. That first we would have our navigators who would have be able to help people generally through the financial assistance process. More complicated cases might then go to ACR Health. And then if need be, then we ask the lawyers at Volunteers Lawyer Project saying, look, we've tried two tiers here and we're not getting anywhere. Can Pastor Craig be assigned a lawyer for his case because we're not getting anywhere, that kind of thing.
So the navigator is answering phone calls, or what is the navigator actually doing?
And we'll work that out. Maybe we'll figure out what that is. But maybe it's just publishing in the church bulletin, monthly bulletin, or even weekly that Doug Wolf has volunteered to be our medical debt navigator for the church. So if you have here's his fax number. Here's when he's golfing. Here's what But this is something we'll figure out together. I mean, I think this is we're not asking for a huge, maybe an hour training and then a refresher once a year or something, and then you'll have ACR Health as your backup in the Volunteer Lawyers Project.
But you're being contacted by people who need help with their financial.
That would be the idea. That I get my bill next week, and I remember, Doug's golfing today, and he's my medical debt. I'm going to sneak up on him on the back green, right? I'm kidding, but the general idea is just that somebody would come to mind for the church, or at the Islamic Society, or Reverend Burns' church, or wherever.
So I haven't been here in a while, but what occurs to me, isn't this what ACTS does? Although ACTS usually chooses one project for the year. But if ACTS already exists, would it not be a way to recruit people to your project?
ACTS doesn't exist anymore.
No, it doesn't.
It doesn't exist. I haven't been here in a long time.
No, unfortunately, they seem to be moribund.
Yeah.
Yeah.
What were you going to
Okay,
say,
thank
Nancy?
you.
I'm sorry, Nancy. What were you saying? It does exist.
It does exist, but it's rebirthing.
Oh, okay.
And it's been rebirthing for 2 decades.
It's been rebirthing for a
Yes,
while.
so it's not really.
But
It is not a vital organization.
But the point is well taken, that we already have a number of networks in town that do similar work. We don't need to reinvent the wheel, but I think we just need to work with what's already existing to strengthen it. Because the point that was brought up is the hospitals don't always do as much as they probably could. So we need to push them to do that. And at the same time, I think we don't want to wait for that. We want to form a network of people that...
Hospitals sure push for the money. I had open heart surgery last year. My first day out of ICU, there was a lady up asking me how I was going to pay the rest of my bill.
Yep.
I had senior insurance and everything.
Yeah.
And she got really kind of, and I said to her, there isn't even a bill yet. And,
Right.
but I ended up, I owed $2,000 in cash and I paid it. But, people get, when they don't want the, it's
my
scary.
father died in March, and they sent the bill to collections.
Oh.
It's just insult to injury, right? It's hard enough dealing with the death, and then it's just embarrassing.
So, Sonny, you would love to have, in leaving here today, you'd love to have at least 5 people volunteer to be trained as navigators?
That would be wonderful. Really, we're just introducing this here today, but that'd be wonderful.
I'm not volunteering, but I'm just trying to hear what the next step is and what you would hope is. And you've spent a lot of time before getting here thinking about these things. And so just thought I'm a person that's practical and just want to help us move along instead of just sit and talk.
Absolutely. Not to be greedy, but I mean, it'd be nice to have one person designated for the church. And then if you're a part of a nonprofit organization and you're willing to do it, great. Or if you want to bring it up to your nonprofit organization and refer them to me, happy to talk with them about this if they're willing to have one person do an hour training and then yearly refresher and be available to people.
But I'm hearing you say we could have a little team here, not just one person.
That'd be wonderful.
And I would welcome that idea to be talked about.
Hi, good morning. Good afternoon, I think. Thank you, Sunny, for doing this. And I just very new to this. We ran into each other, and that's how I learned.
Do you want to introduce yourself? I don't know if everybody knows who you are.
So I'm Indu Gupta. I am a physician, but I went into public health. I was a former health commissioner. I was in private practice. Now I'm an elected official in town of DeWitt. So that's my brief and spectacular introduction. So my journey to all this started with the patients losing their insurance. When the jobs went away overseas or to the other states, and they would not come because they couldn't afford. I had a boutique practice in 90s. And I had zero idea how the insurance system works other than billing and all those things. And I made sure that in my own practice, they did not go into collection because that was the thing. But I had the small sort of a part in it. However, it took me into the journey, which I think kind of shakes our souls, for the lack of the better word, that why are we here? What are we doing, right? So there is that's how I met with Professor Wolf, and he drove me nuts with the statistics class. But I got A in your class. That was great. But it was so great, and I learned a lot. That the data actually speaks the volume. After doing 2 masters in addition, I did once from Maxwell and another from Hopkins for the public health. I thought I'll change the world, but I realized that system is so bad. It's so fragmented. I'm not trying to be a Debbie Downer here. What I'm trying to say that it's a great grassroots effort, but it has to be systematized. And the system, so Sunny alone cannot do that. Plymouth Church alone cannot do that, right? You all spoke about that. Where's the framework to have this initiative so that if for any reason Sunny is not here, somebody else can continue to take care of that. So that's and I applaud you to really going into that and all of you. The second part I want to talk about the hospitals. So hospitals all of them are nonprofit. They have their status, and they do have, as I think many of you talked about, their foundations, but they hide it, and their endowment is pretty big a lot of times, and I don't know. And the same thing is true for the insurance. Blue Cross is nonprofit. Blue Cross Blue Shield is a nonprofit organization. And during COVID, I dealt with them when I was asking them to have the testing free for the people or just charge the insurance company. They did not want to do that. So those things, I literally twisted their arm to pay for the insurance, which was nice. So at least we got, the county got a lot of reimbursement because it's a taxpayer's money. The question comes and somebody raised a question about the self-pay versus insurance. So being in a practice, I could say there are 2 tiers. So when you all get EOBs, right? When you see that. So if you're self-pay, the physician, we were told by all the way the business works is let's say if you came to the first visit and the physician bill is $500, the insurance you have contract with is going to pay only $250. So if you have insurance, that's hoo-ha, that's great. But if you don't have insurance, the person is uninsured, which we have a lot of them now, they are going to force to be paid $250. There's nothing a physician can do that because it's antitrust law. Yeah. So, a lot of times you try to get rid of co-pays and try to kind of look the other way, but most of the physicians in goodwill cannot do that because the system is so broken. I believe, it's my humble opinion, will be the solution lies at the state level because state has all the data. State will, there is the health committee chair at the state level, Senator Rivera, who is from Bronx and who is, I think he could be champion. We have a Senator Chris Ryan. I certainly could talk to him. I don't know how much he's involved. He's in health committee, actually. So I certainly would be happy to talk to him from that point of view. And Pam Hunter, you already talked to him, because there is a way to get the information from the state and the comptroller's office, New York State Annapolis comptroller's office, that we can get those information. It may not be the best, but it could be somehow be a good start. So that is something I would say at the local level. I was a health commissioner. We had the navigator thing, but it's kind of, we don't get data. DSS has a very different kind of data. Department of Social Services have a different kind of data because they deal with the Medicaid. So they're not dealing with most of the time uninsured. I don't think county will have that data. And as far as legislature body, the problem which I have encountered that the hospitals only respond to state. And they have no responsiveness towards the local jurisdiction, whether it's a legislature or the county, because by law, they are supposed to be reporting. The only time we actually worked so well and they listened to the county during the pandemic, because there was no other way around, right? So I'm just giving you some of the part which you will be against when you're trying to find. And I do believe that the solution, part of the solution lies with the state, and that's where we all should work. The nonprofits and the other thing which I am, so when you're talking about, I think it's a great idea to have in the meantime. So there is a high level work, which I mentioned. There is a grassroots, as you are trying to do, should continue as everybody's involved. Navigators, so you're talking about having a trained navigator. They could be 1 or 5 or 10, but still they will be like a small piece in a big ocean. You can do some recorded, you can do, I don't know how much all of you chatbots. I am not a big fan of that, but in some of those things, they could be very helpful to people if any organization. And the biggest question I have, which Sunny, who is we when you're talking about, do you have a separate nonprofit? Are you part of the all? Because it seems like I'm still not able to understand that who is going to be leading as an individual, or you're talking about you have a separate sort of a foundation or separate nonprofit. Then it becomes more responsive. I think the other organization become more responsive.
Yeah.
And data. Data, what kind of data are you looking for?
So you asked about 30 questions, but
yes, I know.
I think the brief version is, what I thought was going to be like a brief fundraising project turned into obviously much more. So I'm hoping that, like you're pointing out, maybe it's the state, maybe it's the county. I don't know, but what we wanted to do was form a task force, including hospitals, state and county officials and local nonprofits, basically, and interfaith, a small group to figure a lot of that stuff out. Because I don't have answers to half those things.
Right. No, I don't either. I'm just raising this question because it does. It's like it's like a Pandora's box. So, medical debt is the most complex thing. And I think your document shows that. I think Maryland has done some of the work and everybody is dealing with that. So it has to be done. And I'll just close that with saying, this is what the government should be doing. This is what the society should be doing for the people. This is a great group of people who are committed to that. And there are many more who are committed to that. They just need direction. They need commitment. And that's what the government's role comes into the picture, to uplift the society. So thank you for what you're doing.
Exactly right. Yeah.
So the United Church of Christ, which is our denomination, partners with the national nonprofit Undue Medical Debt to buy and forgive large portfolios of past due medical debt for vulnerable households. through regional conferences and like our New York conference and local fundraising. The denomination has erased over $100 million in medical debt nationally. That's another source of networking, I guess.
Yeah, awesome.
Thank you.
Thank you. I wondered about that.
I came, Sonny, hoping that the next step might be that our deacons, who are overseeing our social justice ministries, would be willing to take the first step in relieving some local medical debt. But if your numbers are accurate, I want to remind you, you folks have been incredibly generous over the years in supporting our Good Samaritan Fund. And as a pastor, I have learned a long time ago that the more I can use that to benefit big things, as opposed to day-to-day needs, those are important too, then I want to spend money in a way that really maximizes its impact. And so if you are in agreement, I say the Good Samaritan Fund can wipe out that $352. And therefore, then we focus on this piece of the work. Oh, I can say that because you make me the person
You're in charge.
who handles the requests for those things.
Good thing, yes.
So,
Would the deacons need to vote on that? No.
And as a deacon, and there are some here, I would just like to, I appreciate that and know you've done that for a long time. But I also think we're really looking at, first of all, we're looking at someone having potentially really large debt, maybe someone in our congregation, maybe someone that comes to our congregation. So I still just want to celebrate the fact that we have a potential to put together some other sort of partnership or coalition beyond our immediate church.
And I'm going to note that you said that essentially we can leverage large debt once it's been bought, once it has been gone into collections, if you will. Is that the primary tool to be used?
So undue medical debt, once the hospital writes the debt off, then they get it and can, and that's when people work through undue medical debt to retire it.
So essentially part of the navigator's job is to tell the people who are getting dunned by the hospitals, sit, wait.
Well,
is that,
I wouldn't say that. No, I would say that the process is to be as aggressive as possible. We talk to people, don't sit and wait.
Okay.
Go through this process, meet with our navigator, call ACR Health, or if need be, work with Volunteer Lawyers Project 2 as aggressively as possible. Make sure you're taking advantage of every process that's already there under the current law.
Understood.
Just for clarification, and math and numbers and those things are not my forte. How long typically, and I know that probably there's plenty of gray areas here, does it go from the hospital asking for collections to it going to these collection agencies? Is it a year? Is it months?
That's a great question.
Is it?
So there's how long it's supposed to by law, and then there's the reality that was brought up earlier by the woman over here, or like in my dad's case, he died and they sent the bill, he didn't pay it because, oh gosh, he's dead, and they send the bill to collection. So there's what's supposed to happen legally, and it's different from state to state. So in New York State, for example, it shouldn't be anything less than 6 months. You should have 6 months to at least go through the process of all these steps to try to be able to figure out what your plan is. But whether that happens in reality, so that's part of what the that's part of the law. That is the law, what is supposed to happen. But if it's not enforced, and again, there's competing interests here, right? Hospitals want to get paid, insurance companies want to get paid. There's this whole system there's a lot of friction. So there's no easy answer for your question. Sorry, I couldn't give you a more clear answer.
Again, a clarification. I'll ask you to repeat yourself, but what I took from your presentation is that buying out the debt doesn't work in New York anymore because you can't find it.
So
instead, we have to do this because you don't know where the debt is.
Not
Is that
exactly,
right?
but yes. I mean, essentially, that's the quick way of saying it, is that we like I asked Undo repeatedly. You know, tell me what figures can't be right. Tell me, can you update that? Yep, we will. They didn't get back to me, so I called and then I emailed and then I called again, and they came back and said, no, that's all we have on our books. That doesn't mean that's the only debt that's there. That means that particular nonprofit works with hospitals, and that's all that they've been able to buy in this county. Even after going back, and they said over the past month or two, looking for more, that's all that they could find. But that doesn't mean, again, I just want to stress, there's plenty of medical debt out there. And that's another piece of this project too, is that, I talked to a reporter from WAER who wants to go around the community and talk to people about medical debt and find out. And maybe another suggestion was made, may have mentioned this to you, Dr. Gupta, but the county collects data every year. Maybe we add 6 or 7 questions on that annual survey that include medical debt. How much debt do you have? What zip code do you live in, et cetera? Some questions about medical debt that we're gathering regular data.
They do community health assessments every 4 years.
Every 4 years.
So we just did it, yeah, but they cannot, it's anonymous. I think you need a survey in which people can, I don't know, like a community survey. People do respond to these things. But then again, lack of computers and accessibility and all those things, that becomes a lot of intense work.
Yeah.
I just want to mention one other area that's not been touched on, but people make choices about what sorts of procedure or health care from what they're able to pay. And so if their insurance will only give them X amount money back on a procedure, they might skip the procedure. And so that might have a great impact on their health and the length of their life. So I think that's another part that a navigator in our congregation could, or Craig, could receive that information and determine what to do with it. Now I'm also looking at the clock. It's almost 12 o'clock. So I'd like to gather names of people that are interested in this area, not necessarily commitment now to be a navigator, but to learn more. Craig has suggested the deacons would be a good place also. How about maybe Doug Wolf? You turn your name into Doug Wolf, and then he'll pass it on to us. Yes, he'll do it.
It's a tough day for Doug. Thanks everybody for coming, and I'm easy to get a hold of through Nancy or Doug. But I appreciate your attention. Thank you.